Hello students, once again this is Ma'am Quaj. Welcome to the part 2 of our lecture on lipids and lipoproteins. This time we will be discussing its clinical applications. We learned from the part 1 of this lecture on lipids and lipoproteins that cholesterol is a major component of cell membrane and a precursor of steroid hormones and bile acids, whereas triglycerides are the body's major energy store, particularly in adipose tissues. And both of these cholesterol and triglycerides class are insoluble in water or in plasma, and they must be packaged in special molecular complexes known as lipoproteins in order to be transported in the plasma. And two of these lipoproteins that are present in the body are HDL and LDL. LDL, we all know that it is a product of VLDL catabolism and is catalyzed by the enzyme lipoprotein lipase, while HDL is produced by the extrahepatic tissue and serves as a vehicle for the transfer of cholesterol from the tissues to the liver. And these four analytes class comprise the lipid profile test. Class, if there is a good cholesterol, there is also a bad cholesterol. And for your information, as much as I love the topic on lipids, it is also congruent on how much I hate the lipid concentration in my blood. We all know and we all agree that we need cholesterol. We need some cholesterol, but too much of it can raise our risk on having diseases. I'm speaking of the diseases associated with high lipid concentration in the blood, particularly the coronary heart disease. In terms of the lipid and lipoprotein concentration in the blood from different ages and sex, serum lipoprotein concentrations differ between adult men and women. And women are said to be having an average or higher HDL cholesterol level and lower LDL and triglycerides level than men, primarily because of the difference in the sex hormone levels. But this difference disappears the moment that a woman has her menopause due to the fact that the estrogen decreases. Kasi class, the estrogen, which is the female hormone, supposedly to act on liver for the overall reduction of the total amount of cholesterol in the body or in the blood. But since may menopausal na ang babae, this hormone, estrogen, drops, and this drop is associated with the increase or rise in the total cholesterol of the person, primarily because of the higher amount in the LDL and triglyceride levels as well. Men and women both show a tendency toward increased total cholesterol, LDL cholesterol, and triglyceride concentrations with age. So habang tumatanda tayo, expected na rin na tumataas na rin ang ating cholesterol level. Circulating levels of total cholesterol, LDL cholesterol, and triglycerides in young children are generally much lower than those seen in adults. But take note class, meron na rin mga adolescents who experience heart attack. I know, in fact, I know someone at the very young age, at the age of 12, umiinom na po ng medicine to lower her lipid concentration or lipid level in the blood because she's at high risk of having a heart attack. So, delikado po talaga ang mataas na cholesterol concentration in the blood. This table shows the reference ranges of lipids for adults. I think I have addressed this already in the part 1 of this lecture. But in addition to that, I would like you to know how to convert this conventional unit milligrams per deciliter to SI unit millimoles per liter using the conversion factor. And I believe that will be discussed by the succeeding lectures. Here are the guidelines created by the NCEP or the National Cholesterol Education Program of the USA or United States of America, which consists of the list of heart disease risk factors. Example of which is the men of 45 years old and above, and the women of 55 years old and above, or premature menopause for women who have positive risk factors for the coronary heart disease, as well as those who have family history of premature coronary heart disease, those who are doing cigarette smoking, hypertension, and others. The diseases associated with abnormal lipid concentrations is generally termed as dyslipidemia. And this dyslipidemia is caused by several factors. First, genetic abnormalities. Your genetics can also affect your chances of developing high cholesterol. Take note, class. Genes are passed down from parents to children. Certain genes instruct your body on how to process cholesterol and fat. So if your parents have high cholesterol, then you're at higher risk of having it too. An example of this genetic problem associated with abnormal lipid concentration is a very rare case, and that is familial hypercholesterolemia. This genetic disorder prevents your body from removing the LDL, and LDL is the bad cholesterol. Another factor is the environmental or lifestyle imbalances. When there is an inactivity, or you don't exercise regularly, or you're having some vices like smoking, this may also increase your risk of developing high cholesterol. Smoking class may makes your LDL cholesterol stickier, so it clings up to your artery walls and clogs them up. Aside from that, smoking also lowers your level of HDL cholesterol, and HDL cholesterol is the good cholesterol. Another factor that causes this lipidemia is developed from secondarily as a consequence of other diseases. Health conditions such as the diabetes and hypothyroidism might also increase the lipid concentration in the blood. Dyslipidemia is also associated with coronary heart disease or arteriosclerosis. Arteriosclerosis class is a very serious condition. It can limit the flow of blood to your arteries. It also raises your risk of developing dangerous blood clots. Now, this arteriosclerosis and dyslipidemia is related to each other. The relationship between the two is from the deposition of lipids, mainly from the esterified cholesterol, primarily in the artery walls. This lipid deposition class starts from the fatty streaks, and these fatty streaks is the thin streaks that are present in the macrophages in the subendothelial space, and these fatty streaks may develop over time, forming plaques. So, pag kumakapal na or lumalaki na yung plaques in the artery walls, definitely this may lead to can partially block or occlude the blood flow. And sometimes then, pag maging established na yung plaque, this may trigger thrombosis, and this may trigger thrombosis because pwede siya mag-erupt pwede siya mag-rupture, pwede siya pwede siya mag-rupture, and this may trigger thrombosis that can also block the circulation. So, when plaque develops an arteries in the arms or legs, it is called as the peripheral vascular disease. But when it develops in the heart, it is referred to as coronary artery disease. And when it develops in the vessels of the brain, it is called as the cerebrovascular disease. And this cerebrovascular disease is associated with stroke. And the coronary artery disease is associated with myocardial infarction, or commonly known as MI. There are two categories of this lipidemia class. These are the following: hyperlipoproteinemia and hypolipoproteinemia. One of the two major categories of this lipidemia is hyperlipoproteinemia. And this hyperlipoproteinemia refers to the diseases associated with elevated lipoprotein levels. And this hyperlipoproteinemia is further subdivided into three subdivisions, and these are the following: hypercholesterolemia, hypertriglyceridemia, and combined hyperlipidemia. The first subdivision of hyperlipoproteinemia that we will discuss is the hypercholesterolemia. This lipid abnormality is most closely linked to heart disease, and the person who has this disease has an elevated LDL cholesterol level. One of the genetic abnormalities that is associated with hypercholesterolemia is what we call the familial hypercholesterolemia. This genetic abnormality, the problem with this genetic abnormality is that the individuals synthesize intracellular cholesterol normally but lack or are deficient in active LDL receptors. And take note class, the population who have this familial hypercholesterolemia is 1:500 in the population. Familial hypercholesterolemia is associated with high risk of premature coronary artery disease. And one of the signs and symptoms of this genetic problem is the tendinopathies, which are found on the backs of the hands, knuckles, and the Achilles tendon, meaning to say the cholesterol deposits are found under the skin. And also the arcus, from which the cholesterol deposits are found in the cornea. So whenever a person has this familial hypercholesterolemia, of course, family screening is generally important, as well as the aggressive prescription. The succeeding slides class will be the photographic pictures or the pictures of the symptoms of this genetic familial hypercholesterolemia. Another subdivision of hyperlipoproteinemia is the hypertriglyceridemia. This is the result of an imbalance between synthesis and clearance of VLDL in the circulation. Hypertriglyceridemia can be a consequence of the genetic abnormalities such as the familial hypertriglyceridemia. This is very tongue twister. Again, hypertriglyceridemia can be a consequence of the genetic abnormalities such as the familial hypertriglyceridemia, or the result of the secondary causes such as the hormonal abnormalities associated with the pancreas, leading to secondary hypertriglyceridemia. And this hypertriglyceridemia is a life-threatening abnormality because it can cause acute and recurrent pancreatitis, and it may also increase the risk of coronary artery disease. Take note class, when you say hypertriglyceridemia, hyper meaning high, emia means blood level. So this denote high blood levels of triglycerides. The degradation of triglycerides to free fatty acids can lead to cytotoxic injury resulting to local injury that increases inflammatory mediators. So kung sobrang taas na ang triglycerides mo, this might damage your pancreas leading to pancreatitis. The third subdivision of hyperlipoproteinemia is the combined hyperlipoproteinemia. From the word combined, it defines as the presence of elevated levels of both serum total cholesterol and triglycerides as well. Dahil combined na nga siya, the risk of having coronary heart disease also increases or highly increases. The genetic disorders or genetic forms of this combined hyperlipoproteinemia are the following: familial combined hyperlipoproteinemia and familial dis-beta lipoproteinemia. Familial dis-beta lipoproteinemia is more rare compared to the first one, and familial dis-beta lipoproteinemia is also called as type 3 hyperlipoproteinemia based on the lipoprotein typing system developed by Fredrickson et al. And for your information, this familial dis-beta lipoproteinemia is the mutation or is a disease that causes a mutation in the apolipoprotein E or apoprotein E that serves as the ligand for the liver receptor for chylomicrons and VLDL. So here is the lipoprotein typing system created, developed by Fredrickson and friends, Fredrickson et al. When we speak of hyperlipoproteinemia, we cannot afford not to talk about the lipoprotein A elevation. And when there is an elevation in the lipoprotein A concentration in conjunction with the increase of LDL cholesterol level, there is an increased risk of having coronary heart disease as well as the cerebrovascular disease. And the plasminogen, which is considered as the major enzyme that degrades fibrin clots, will be blocked by this elevation of the lipoprotein A, leading to formation of clots along the arterial wall that will not be dissolved. Hypolipoproteinemia is defined as the abnormalities that have marked decrease in lipoprotein concentrations, and this condition exists in two forms: hypoalpha lipoproteinemia and hypobeta lipoproteinemia. Hypobeta lipoproteinemia is a disorder consisting of low levels of LDL cholesterol or apolipoprotein B. Another form of hypolipoproteinemia is the hypoalpha lipoproteinemia, and it indicates an isolated decrease in the circulating high-density lipoprotein. The laboratory results that indicates this the condition is the presence of the HDL concentration, which is as low as 1 to 2 milligrams per dl or 0.03 to 0.05 millimoles per liter, and total cholesterol level as low as 50 to 80 milligrams per dl or 1.3 to 2.1 millimoles per liter. And this condition is the presence of or show the presence of mutation in the ABCA1 gene or ABCA1 transporter, which mediates the first step of the reverse cholesterol transport pathway, which is one of the major pathways in the generation and transport of lipids within the body. And a good example of the disease associated with this hypoalpha lipoproteinemia is the Tanger disease. Some features of the Tanger disease is the presence of the clouding of the clear covering of the eye, as shown by this picture, and also the presence of the orange colored tonsil. LCAT, or termed as lecithin cholesterol acetyltransferase, is an enzyme that helps transport cholesterol out of the blood and tissues by a process called cholesterol esterification. And this disease, which is the LCAT deficiency, is characterized by two forms: complete or homozygous form and the mild heterozygous. The features or the conditions of this complete LCAT deficiency are the following: corneal clouding, nephropathy, hemolytic anemia, and HDL deficiency. While for the mild LCAT deficiency is the feature of having the fish eye appearance or symptom. I guess that would be all for today's lecture about the lipids and lipoproteins. I hope you learned a lot from this lecture, students. Thank you for listening. And as usual, before I will end this lecture, I would like to say some words of encouragement or some words of wisdom. Be strong and courageous. God is with you. Thank you. Be safe and God bless everyone.